In this quick video, we're going to talk about the principles of nephron function. As you've probably learned, nephrons are the individual functional units of both kidneys. There are about 1 million and change nephrons per kidney. And there's different components to nephron function that are important in maintaining extracellular balance and milieu. We're going to embark on that using some of the principles that we've already learned about from the standpoint of Starling forces by moving to the concepts of glomerular filtration. Now, I've put a schematic on the board here, and let me take you through it again. It is a schematic of the glomerulus, where the glomerulus is very similar to the capillary systems that we've talked about in the systemic circulation. So the glomerular capillaries will form that basic system. However, they are different because they are surrounded on the afferent side by an afferent arteriole. And after the capillary, there is actually an efferent arteriole. That means that flow of blood and plasma through the glomerulus can be very tightly controlled by altering both the afferent and or the efferent tone. Okay? I've kind of combined all of the 2.5 million nephrons in both kidneys into a single solitary nephron to illustrate the filtration across the glomerular capillary. And just like the systemic capillaries, we have the same types of forces in place. We have the hydrostatic pressure within the glomerular capillary. We have oncotic pressure within the glomerular capillary that are going to impact on fluid movement out of the capillary into the nephron. And then in the nephron, the very beginning of the nephron is called Bowman's space. So we have similar driving forces and pressures in Bowman's space, which I'll depict as the hydrostatic pressure within Bowman's space and the oncotic pressure within Bowman's space. Now, in order for fluid to get from the capillary into Bowman's space, it's got to traverse the capillary membrane, the glomerular capillary membrane. And that capillary membrane has three basic properties. Three basic components. The first component is the capillary endothelial layer, which acts as a rough sieve to keep back cellular elements inside the capillary. The second portion of the glomerular filtration barrier, black's not going to work, is the glomerular basement membrane, which has a general negative charge. And finally, as a component of an external factor, we have podocyte foot processes, which you can read about in the text. And between the podocyte foot processes and the basement membrane, the net charge across that membrane is negative. And that's going to be important from the standpoint of excluding certain substances from the glomerular filtrate. So from the standpoint of deciding the net flow across this glomerular filtration barrier, we can use the same Starling equation that we used for systemic capillaries, which is essentially flow is equal to, again, our filtration coefficient times the difference between hydrostatic pressures in the capillary minus hydrostatic pressures in Bowman's space minus the sigma, which is the reflection coefficient, times the difference between the oncotic gradient, which would be the oncotic gradient in the glomerular capillary minus the oncotic gradient in Bowman's space. same type of formula as we had for systemic capillaries. The difference, however, will be that this is such an excellent barrier for protein movement that sigma is 1. It sets up an exceptionally strong oncotic gradient, an effective oncotic gradient, and it excludes most protein from moving from the capillary into the area of Bowman's space. So it effectively changes the oncotic pressure in Bowman's space to 0. And so therefore this factor of the equation drops to 0 as well. And so we can rewrite this equation as a function of GFR, glomerular filtration rate, so flow from the glomerular capillary across into Bowman's space, is equal to the capillary hydrostatic pressure, minus the hydrostatic pressure in Bowman's space, plus the oncotic pressure in the glomerular capillary. And that is the major determinant of GFR. So anything that will impact predominantly on the capillary hydrostatic pressure, the glomerular capillary hydrostatic pressure, will have a major impact on how much fluid is moved across that glomerular filtration barrier and impacting on GFR. So just to give you a quick overview and idea of how much fluid we're talking about, the average cardiac output per day is about 7,200 liters per minute. If you do the math, 5 liters a minute times as many minutes as there are in a day. Of that, about 25% is gone through the kidney. So renal blood flow is actually equivalent to about 1,800 liters per day. Oops. Sorry, this should be day, not minute, huh? Of that 1,800 liters that flows to the kidney as in the form of renal blood flow, glomerular filtration can be as high as 180 liters per day. So we're talking an awful lot of fluid filtering across this general membrane, and the major constituent that's regulating that is the glomerular capillary pressure. Okay, so next we're going to talk about how the filtrate, after it's filtered through the glomerulus, is processed, again, in broad brush strokes. In order to do that, we first have to talk about epithelial transport. And you're familiar with epithelial monolayers. And actually, if we go back to the idea of body fluid compartments, it's actually the epithelial cells that separate the extracellular fluid compartment from the outside world. And so it's the epithelial monolayers that actually have an impact on maintaining the integrity and the composition of the extracellular fluid compartment. And epithelial cell monolayers have several unique characteristics, very different from symmetrical cells like muscle cells and nerve cells. Again, a schematic, if you will. And what I've done is labeled this so that this is the luminal side. The luminal side is the side that is closest to the outside world. And that luminal side has an apical membrane, so you'll also see it designated as apical side. And on the other side is a basolateral side, also referred to as the serosa, which is the side that is in contact with the blood. Those two membrane domains, the apical membrane domain and the basolateral membrane domain, are separated by tight junctions. And those tight junctions also have very specific properties that can have an impact on transport. Some of these tight junctions are tight junctions, and some of these tight junctions are loose or leaky tight junctions, depending on the tissue that we're in. Now, you notice that there are two absolutes for epithelial transport. So epithelial transport involves getting substances, solutes, water, or other organic molecules from the luminal side to the serosal side, or from the serosal side to the luminal side. So transport across this monolayer. There are two absolutes that need to be in place for one to get transport across that monolayer. The first is you need a route or a pathway, and the second is you need a driving force. There are only two routes. The first route is through the cell, that's transcellular. The second route is between the cells, or paracellular. But you have to have a route. Para or trans. That brings us to driving force. There are two driving forces as well. There is a chemical driving force, which corresponds to chemical or concentration gradients that exist. And then there are also electrical driving forces. And those electrical driving forces are harnessed by charged particles to move. Now, I've already talked about the two routes, but I will tell you that from the standpoint of driving force, everything for the driving force is established by the sodium-potassium ATPase and an associated pump leak within the epithelial cell. That pump drives all transport across the epithelial monolayer in the nephron. It not only drives transport of the specific solutes of sodium and potassium, but it also drives transport of other molecules like amino acids, glucose, water, based on coupled transport and osmotic gradients. The important aspect of the apical and basolateral membranes as well in an epithelial monolayer are that because they're separated by tight junctions, they can actually have different biochemical properties. So there can be different transporters in the apical membrane compared to the basolateral membrane. And because they have different biochemical properties and different transporters, they can actually also have different electrical properties. So we're used to seeing symmetric cells, which essentially the membrane potential is the same no matter what part of the cell you measure it in. For epithelial cells, there are different membrane potentials, or can be different membrane potentials, across the apical membrane compared to across the basolateral membrane. Let me show you what I mean. If you take an electrode and ground it in the basolateral side, in the serosa, and you move that electrode across the basolateral membrane in this particular situation, you'll see that, for example, we'll get an 80 millivolt negative hyperpolarization as we cross into the cell. So the membrane potential across the basolateral membrane is negative 80 millivolts. As I move that electrode across the epithelial monolayer and I get to the apical membrane, I cross the apical membrane and the depolarization is only of a change that may be 70 millivolts, minus 70 millivolts. So I don't come all the way back to zero. And that's because of the different properties that may be existing at the level of the apical membrane and its different membrane transporters and the different concentrations across the apical membrane. So the apical voltage and the basolateral voltage are not necessarily the same. What's powerful about that is that it allows me to establish an transepithelial voltage that's actually across the monolayer in this particular situation, which amounts to minus 10 millivolts. So there's actually a potential difference in a potential gradient across the monolayer that will come up from the standpoint of transport in the next example. All right, so let's use this next example to illustrate the importance of that transepithelial voltage. So we have the same cell here, luminal side, tight junctions, basolateral side, apical membrane, basolateral membrane. We have our basolateral sodium-potassium ATPase with its associated pump leak. And on the luminal side, we have sodium and chloride in solution. And we want to reabsorb or move sodium and chloride from the apical side, the luminal side, across into the basolateral area of the serosa. This is an example of transepithelial transport and as well as sodium reabsorption, and this particular cell type occurs in the collecting duct of the nephron. And the mechanism for reabsorption of sodium is the existence of a sodium channel in the apical membrane of the cell monolayer. And sodium, because the sodium pump makes sodium low, the concentration inside the cell low, and the potassium concentration inside the cell high, sodium reabsorption through that channel goes down its chemical gradient into the cell very easily. The chemical gradient is actually very large. And remember, in addition, we have a minus 80 millivolt electrical potential inside the cell as well that's also accelerating sodium movement from outside the cell into the cell. So for sodium movement, we have both an electrical and a chemical driving force. And as long as we have a root in the form of a sodium channel, sodium moves very easily down that gradient into the cell. And once it's into the cell, it hops on the sodium-potassium ATPase and is transported across into the serosa. So we've moved sodium across the monolayer without any difficulty. The trick comes for chloride. Now there's no chloride transporter in the apical membrane. Chloride moves, however, because as sodium moves into the cell, it leaves behind chloride, and that generates a lumen negative potential. So the transepithelial potential across this monolayer has a lumen negative charge compared to the serosa. And that lumen negative charge drives chloride in a paracellular route down its electrical gradient over to the serosal side of the membrane, over to the serosal side of the monolayer. So we've moved sodium and chloride simply by causing the sodium-potassium ATPase to change the concentrations and the voltage within the cell. And then we've developed a lumen potential difference across the monolayer that drives chloride in addition. And so the net result is movement of sodium and chloride from the lumen across the monolayer into the basolateral side of the system. Okay, so now that we've filtered the plasma and the ultrafiltrate has come through the glomerular filtration barrier, and we've talked a little bit about the general principles of epithelial transport, let's talk about the overview that occurs from the standpoint of the nephron and how substances are reabsorbed. And again, I'm not going to go into the specifics of the cellular models along the different segments. I'd refer you to your textbooks for those specific models. I think they are important, and conceptually they're important to figure out what's going on from that perspective. But this is going to be an overview to give you some insight into the different components of the nephron and what they're responsible for from the standpoint of sodium and water reabsorption. So again, I've taken all 2.5 million nephrons roughly and laid them out in 2 dimensions. And I'll take you through and label these. We have the glomerulus up here, the glomeruli. This big fat portion that's directly after the glomerulus is the proximal tubule. We have the thin descending loop of Henle, although some people would say the descending loop of Henry, but that's for Dr. Henry to worry about. And then we have the loop that comes down to the very deepest part of the kidney in some of these nephrons. We also then have the thin ascending loop of Henle. Again, lowercase t to differentiate the thin limb. And here we have the thick ascending limb of Henle. After this particular bend, we develop into the distal tubule, the collecting duct. The collecting duct is the latter portion of the nephron, and the collecting duct has 2 major components. There's the cortical collecting duct, which is present in the cortex of the kidney, and then there is the medullary collecting duct, which is down below that differentiation line between the cortex and the medulla. Okay, so that's anatomically what we're looking at. The cells in each one of these segments have different structures and therefore different functions. So let's begin with the glomerulus and let's talk about sodium as the prototype. We'll talk about sodium and we'll talk about water from the standpoint of reabsorption. So, as I said before, about 180 liters per day enter the glomerulus and begin its transit through the nephron. If you do the math, the filtered load, so let's talk about the filtered load, is equal to the GFR, which is 180 liters per day, times the plasma concentration of a particular substance. And for this case, we'll talk about sodium. So the filtered load of sodium is equal to the GFR times the plasma sodium concentration. If we do the math, that amounts to 25,000 milliequivalents of sodium per day is filtered at the level of the glomerulus. So that's freely filtered into the glomerulus, and we have to be able to reabsorb not only that 180 liters, but the vast majority of sodium that's filtered. And that's the response of the nephron. So as we go through each segment of the nephron, we'll find that in the beginning, in the proximal tubule, about 67% of the filtered load of sodium and water is reabsorbed. In the thick ascending limb, about 25% of the filtered load of sodium is reabsorbed. There is no water reabsorption in the thick ascending limb. This segment is water impermeable. As a matter of fact, the thin ascending limb and the thick ascending limb and the early portion of the distal tubule till about the midway until we get to the cortical collecting duct is actually water impermeable. So there is no water transport along these segments, only solute transport in the form of predominantly sodium. In the distal tubule, we have about 7 to 8% of the filtered load of sodium is reabsorbed. And then when we get to the cortical collecting duct and the medullary collecting duct, combined, we get somewhere between 1 to 3% of the filtered load of sodium, so that we usually get in the urine less than 1% of the filtered load of sodium excreted. And I think my math comes out reasonably closely. The general consensus here, the general thought process that you should be thinking about conceptually is that The proximal nephron is responsible for bulk transport, and so carries the lion's share of reabsorption of solutes, which would include sodium, potassium, calcium, phosphate, water, glucose, and amino acids. All of that transport occurs in the proximal tubule. It's a workhorse. It reabsorbs 2/3 of the filtered load of the system. It also has a unique component in that it is isoosmotic reabsorption. And so that means that as solutes are reabsorbed, water is reabsorbed along with it, and the osmolality of the luminal fluid remains essentially unchanged as you go from the glomerulus through to the late phase of the proximal tubule. The thick ascending limb is responsible for a slightly less amount of solute reabsorption, and because this segment is water impermeable, along with the early phase of the distal tubule, this becomes a diluting segment. And so movement of solute out of the luminal fluid in the thick ascending limb and the distal tubule begin to dilute out the luminal fluid. So the osmolality in the luminal fluid of the thick ascending limb and the distal tubule is actually less than that of plasma. And finally, as we move into the distal segments of the nephron, the cortical and medullary collecting duct, we have a much smaller amount of the filtered load that's reabsorbed. But this is the phase where fine-tuning of the excretion amount occurs. So that fine-tuning is important because in order to maintain appropriate levels of sodium and water in the system, regulation of excretion of sodium and water occurs at the level of the collecting duct. So fine-tuning and regulation for normal everyday balance occurs at the level of the collecting duct.